All right, Pulsus Paradoxus, here we go. Anybody know what that is? Oh, we talked about that a little bit in lab. So, way back in 1873, a guy named Kussmaul, Adolf Kussmaul, Adolf Kussmaul, we'll just call him. He's the same guy who discovered Kussmaul's sign. He noticed a strange paradox in a patient who ultimately died from cardiac tamponade. Remember, we said cardiac tamponade is when that pericardial cavity gets filled up with something. Could be blood from a DeBakey 2 aneurysm. Now you know what those are, or Stanford A. It could be from pericarditis and a really particularly neutrophil heavy infection has caused a lot of pus and inflammatory juice to fill this cavity, whatever. It's typically seen in patients with cardiac tamponade, and that's where Kussmaul found it. And he noticed this weird paradox. He noticed that when he was taking the patient's pulse, the pulse would regularly disappear. And when he looked at the patient more closely, he noticed it disappeared every time the patient breathed in. And when he breathed out, it came back. So that's really strange. So he got his stethoscope out and thought, well, the heart must be skipping when he's inspiring. And it didn't. The heart was normal. A normal, steady S1, S2 heart rhythm was there. So how can that be? And that was the question for many, many years that went unanswered. And they still can't agree on it 100%, but most of them explain it as how I'm going to explain it to you. So we have to remember a little physiology. So here's the blue side of the heart is really squishy. Remember from Gross 2, that side of the heart is really flabby and it can stretch like crazy. Not true of the left side of the heart. It's much more muscular. When you take a breath in, especially a deep breath, the thoracic cavity becomes like a vacuum and it sucks blood into the right side of the heart. Which is fine normally because the right side of the heart can expand to accommodate that blood. We talked about in the lab, when you take a deep breath in, do the AV valves close at the same time, or the semilunar valves, do they close at the same time? We said no. If you have more blood in the right side of the heart, it takes longer for the blood to process, and this pulmonic valve will close after the aortic valve because of this phenomenon of kind of sucking more blood into the heart. So what happens if you squeeze the heart and the right side of the heart can't expand and you breathe in? Where does all this blood go? So that is the Pulsus Paradoxus. Is you think of it as the heart is strangled, but not horribly strangled. There's a little bit of give still, but still not enough to offset this inspiratory kind of sucking in of blood. So what happens is the right ventricle bows out a little bit, but that's not enough. So something else has to give. And what gives is the interventricular septum. It pushes the interventricular septum into the left ventricle, and that's going to shortchange the left ventricle out of blood. So you get a decreased filling of the left ventricle during inspiration. If you have a decreased filling of the left ventricle, what's going to happen to your blood pressure during those contractions? If you're not ejecting a lot of blood, is the blood pressure going to be high or low? It's going to be low, and that's what Pulsus Paradoxus is. It's a decreased filling of the left ventricle, and the theory is because the interventricular septum has pushed into it and shut that down. But the key is that there's still enough room for a little bit of expansion of the left or of the right ventricle. Kussmaul's sign is exactly the same, but it's worse. It's a more severe strangling of the heart, and it can't expand at all. So in someone with Kussmaul's sign, when they take a breath in, the interventricular septum will collapse, and you'll get a decreased ejection fraction, and you'll get decreased blood pressure. But there's nowhere for all this other blood to come because you've already pushed the interventricular septum over, and so it actually beaver dams. It actually backs right up into the external jugular vein, and it bugs out your jugular vein. And you can see that on people. It also goes down into your liver and it blows up your liver as well. And there's a test we'll look at. So that's kind of where we're going with this thing. So here's everything we said. So here's a normal heart without any tamponade. No strangling going on of the pericardial sac that surrounds the heart. And this guy took a breath in, and here's all the extra blood. That's fine. So we just blew out the wall of the heart here, of the right heart. We didn't even have to collapse the interventricular septum. So the left heart is pretty normal as well. Now we might get a little stuttering of this valve, which I said you need a cardiac stethoscope to hear that delayed closure. But it's not the left ventricle's fine. So you'll get a normal amount of blood pressure. There'll be no pulsus paradoxus with this. Maybe a little bit of physiological splitting though. Okay. But now what happens if the pericardial cavity is filled up with fluid? That's called cardiac tamponade, of course. And normally the right heart can't expand enough to accommodate all the extra blood coming in. Let's just look at the picture. And what gives is, as I said, the interventricular septum gives in. And then that cheats the left ventricle out of blood. So if you don't have a good cardiac output, or ejection fraction, or whatever you want to call that, gushing of blood out of the heart, if it's decreased, you're going to have decreased pressure, and you're not going to be able to palpate the pulse on someone with decreased pressure. It's not strong enough to make a pulse. So here's someone with cardiac tamponade. Let's say they had a pericarditis and their pericardial cavity is filled up with fluid. They take a breath in, and we can get a little bit of expansion here, but not enough to completely offset the problem. And so the interventricular septum collapses, and you can see what's happened to the left ventricle. Here's a normal left ventricle. You can see it has much greater space, much greater volume. This has got a little skinny volume, so when systole occurs, there's not going to be a lot of bloodshot up here, and there goes your pulse, there goes your pressure. Question?
Would the left side try to compensate with that by pushing harder?
They think that's a very good question. They struggle with that, but they think that phenomenon happens when the left ventricular wall stretches out, and it's not stretching out, it's collapsing inward. So there's not a lot of stretch, so that mechanism doesn't work. But the people do argue over that. Very good question. Okay, but the key is the right ventricular wall is able to accommodate some of it, and then the interventricular septum stretches to accommodate everything else. But the left ventricle is messed up. It lost volume because the interventricular septum is pushed right into it. Okay, so that's pulsus paradoxus. There's a definition for pulsus paradoxus. You can measure pulsus paradoxus. I used to go way into the weeds on this, but I'm not going to do it anymore. I don't think it's high yield board stuff. But if you have a drop in blood pressure during inspiration by more than 10 millimeters, you're diagnosed with pulsus paradoxus. And you need to check the pericardium very closely at that point. And you basically put, how you do it, I'll just explain, I won't test you on it, but you put a blood pressure cuff on, the patient take their brachial pulse, pump it up till you find the cutoff pressure. Okay, let's say it's 120. And then you just leave the cuff at 120, and you just feel it, and it should be steady. You watch them breathe, there's no change in pulse. Now, if you do this technique and all of a sudden their pulse starts disappearing when they breathe in, then you suspect pulsus paradoxus. Why is their blood pressure dropping to the point you can't feel the pulse anymore during inspiration? So what you do is you let 10 millimeters of air out of the cuff, take it down to 110. And is the phenomenon still there? If it still disappears at 110, they have pulsus paradoxus. If it's back to normal, if it doesn't disappear during inspiration anymore, then they don't. But I mean, it raises an eyebrow. So that's how you test it. And you could go down further. You could take it down to 100. Does the pulsus paradoxus still exist at 100? If it does, I mean, that's more serious. That's the way you can test it. Okay, so another phenomenon. What if they have COPD? Let's go back to our picture. So we said the lungs are over here, Normally, when you take a breath in, not only does it suck new blood into the right heart, but it holds blood, a little bit of blood in the lungs. Blood doesn't like to leave the lungs when you're in full inspiration. And so that kind of cheats the left ventricle out of a little blood. Normally, it's not that big a deal. But people with COPD who have a lot of scar tissue and they have pulmonary hypertension, that effect is exacerbated. So when they take a breath in, the lungs really hold on to the blood much greater. And so just that in and of itself can cheat the left ventricle out of filling. And so during inspiration, if you cheat the left ventricle, no matter what the cause, you're going to have a decreased blood pressure during those contractions of the heart. So much so that you might lose the pulse when you're trying to palpate it. So people with COPD also can have pulsus paradoxus. And in fact, here are the things. You definitely want to know this slide. Cardiac tamponade is classic for pulsus paradoxus, usually from infectious pericarditis, which we talked about last time, but could be from other things. COPD patients, the 3 Cs actually, and people with chronic asthma, they can all have pulsus paradoxus. These have to be more severe further down the road, but this can be, immediately this one can start. So definitely, that's a nice question. Guarantee you that one's going to be on there. Kussmaul sign, as we said, is very similar to pulsus paradoxus. And again, they argue about the cause of this, but here's what the consensus seems to think is what I'm teaching you. It's a visible bulging of the external jugular vein, and they won't call it the external jugular, they'll just call it the jugular vein, but it's really the external jugular vein. The internal is wrapped in the carotid sheath. But it's a bugging out of the external jugular vein, and if you have the patient take a breath in, it really bugs out like crazy. Normally, in a normal person, if you take a breath in, this blood is sucked into the right heart and it should disappear. Because if you put someone up at a 45-degree angle on a, let's say, our bench over there, their jugulars might, especially if they had a salty lunch, lots of salt, blood pressure might be up a little bit, their jugular might poke out a little bit. You have them take a breath in, that thing will disappear or nearly disappear. It certainly is not going to bug out and get much bigger during inspiration, and that's a Kussmaul sign. Lay the patient down, have them take a deep breath, and watch their carotid or their jugular vein here. Make sure it doesn't bug out. If it bugs out, it's concerning. So these are more severe stranglers, conditions that it's not just fluid that's surrounding the heart. Fluid's got a little give to it, like cardiac tamponade. This is like scar tissue surrounding. The fluid has turned into scar tissue, so you have scar tissue surrounding your heart, and that's typically the cause of this. There's 2 types of causes we'll look at, but they're both, the pericardial cavity has filled up with strangling scar tissue, and it has no mercy at all. And as we said before, where's the picture? Did I not put it on the picture here? Let's go back to the picture. But as I said before, when this person takes a breath in, this doesn't move. The right wall of the heart is frozen with scar tissue. There's no give. So the interventricular septum goes first, but that's not enough to compensate for all this blood trying to get in. So you get yourself a beaver dam here, and blood just backs right up the superior vena cava, gets into the external jugular vein, and it bugs that thing out. And it goes down into the liver. You can't see that, of course, but the liver also fills up with blood during expiration. So other conditions can cause this besides heart problems. What if this tricuspid valve is full of calcium and it doesn't open very good? Tricuspid stenosis, same thing. Take a deep breath, blood comes in, it hits this stiff and sticky non-opening tricuspid valve, can't get in, so it goes right up and blows out your jugular, goes into your liver. So other things can cause this as well. Pulmonic valve could do it too, but not, you could still bow this in. So it's usually tricuspid valve stenosis. Or what if you get a blood clot, a DVT comes up from the lower extremities, up the popliteal vein, the femoral vein, gets into the inferior vena cava, and it gets stuck right here, beaver dam. So an embolism could also cause this problem as well. What about right heart failure? Could that cause it? It could cause it, just like left heart failure. If the right heart is not processing blood and it's failing, you're going to have all this blood waiting to get in. That's going to back up into your jugular vein. Okay, so that's the story with Kussmaul's sign. Now, what are the causes of who are these severe stranglers, I call them? More than fluid. There's really two of them you need to know. There's constrictive pericarditis and there's restrictive cardiomyopathy. And pericarditis, we've studied that one. That was an infection usually or an inflammation of the pericardium, and fluid has gotten into the pericardial cavity and started to collect. But what happens in some people is that fluid turns into scar tissue. Most people, that fluid is just reabsorbed by the body, no big deal. In some people, it turns into scar tissue and it stays there permanently. That's called constrictive pericarditis. Restrictive cardiomyopathy is kind of a general term, but this is the myocardium of the heart starts getting filled up with scar tissue. Amyloidosis is classic at causing scar tissue in all sorts of tissues. So amyloidosis could cause restrictive cardiomyopathy as well. Okay, so all of these conditions, they strangle the heart. So you're going to have Pulsus Paradoxus, but in addition to Pulsus Paradoxus, you're going to have a Kussmaul sign as well. If you have cardiac tamponade, the strangling's not that bad. You'll have positive Pulsus Paradoxus, but you're not going to have a Kussmaul sign with that. See how that works? All right, that's everything I said. So about 33% of the time, someone with a positive Kussmaul sign, it is constrictive pericarditis, where that thick scar tissue builds up in the pericardial cavity, strangles the heart, really strangles it. Right heart can't expand as well. They will have Pulsus Paradoxus. Restrictive cardiomyopathy, as I said, that is some condition of the myocardium of the heart that deposits some type of tissue, like amyloidosis, sarcoidosis, hemochromatosis. You get iron deposits in your heart. It makes the heart so stiff that it can't expand. The right heart can't expand to accommodate that blood if the myocardium is super, super stiff. Pulsus Paradoxus will be present there as well. And here's the classic chart. So Kussmaul sign, constrictive pericarditis, yes. Pulsus Paradoxus, yes. Restrictive cardiomyopathy, Kussmaul sign, yes. Pulsus Paradoxus, yes. Cardiac tamponade, not a severe strangler. Pulsus Paradoxus, yes, but it's not bad enough to force the blood all the way up into the jugular vein. So no Kussmaul sign in cardiac tamponade. Okay, should be like a zillion stars on that slide. What else can block the flow of blood? We already said this, right heart failure, whether it be cor pulmonale. What was cor pulmonale again?
It's when there's so much liquid and so it squeezes the heart.
That's cardiac tamponade. Cardiac or cor pulmonale is right heart failure that is caused by a lung-specific disease, like COPD. COPD causes right heart failure. Specifically, that type of right heart failure is called cor pulmonale. It's an AKA for right heart failure, but the cause is the key. What's the most common cause of right heart failure? Left heart failure. Would you say the patient has cor pulmonale in that situation? No, because the primary cause is not a lung disease. As I said, tricuspid valve stenosis, pulmonic valve stenosis, I keep wanting to take that out of there, and a pulmonary embolism. Everything I've already said there. They all create a beaver dam. That's a beaver. Okay, there is another way to test for this called the hepatojugular reflux test. And what does that look like? That looks like palpating the inferior border of the liver, and it's exactly the same technique. So if you suspect someone has some type of strangling of the heart going on, like cardiac tamponade or any of those conditions that put fibrous tissue inside the heart or inside the pericardium, you can test that theory by having the patient breathe in and then hold it and then push your fingers hard underneath the rib cage to compress the liver. Not the most comfortable test in the world. But if the liver is overfilled with blood, it'll drive the blood up the inferior vena cava into the heart, but oh no, it can't get into the heart, so it'll go through the right atrium up the superior vena cava, and the jugular vein will bug out as you push. You can watch this being done. So that's the hepatojugular reflex test, and it should cause a Kussmaul sign. Okay, everything I just said. Let's see. What could cause this positive jugular reflux test? Right heart failure, blood flow blockage from right heart failure, an embolism, all the things we talked about could cause this. Right, there's a YouTube video if you have time to watch, patient, where the doctor does this hepatojugular test and this thing bugs out during the test. She had right heart failure.